I'm Sangmin Park, and I'll share our multi-center results of biportal endoscopic discotomy for cauda equina syndrome. A migrated herniated nucleus fragment compresses spinal nerves, producing severe low back and leg pain, which is our surgical target. Cauda equina syndrome manifests as lower extremity weakness, saddle anesthesia, and bladder or bowel dysfunction. Timely decompression is critical. Non-operative care is futile here. Surgical choices range from open or microscopic discectomy to endoscopic infusion techniques. We focused on endoscopy. Surgery within 48 hours offers the best chance to restore sphincter control and motor function. According to previous studies, uniportal endoscopic discectomy data show shorter stays, faster return to work, and less opioid use, though with longer OR times. However, there is no studies about biportal endoscopy data in cauda equina syndrome. The purpose of our study is to evaluate one-year clinical and surgical outcomes of biportal endoscopic discectomy for lumbar disc-related cauda equina syndrome across 3 hospitals. Single-level large fragment herniations which had more than 70% canal compromise at L2 to S1 with acute CES were eligible. Upper lumbar disease, non-disc etiologies, or open surgery cases were excluded to maintain a homogeneous cohort. 2 independent portals, 1 viewing portal and 1 working channel, enable wide visualization yet minimal tissue disruption. I show 34-year-old female case which is diagnosed as L5-S1 cauda equina syndrome. As demonstrated in the video, we approach from the right side and perform a partial resection of the ligamentum flavo, removing approximately 3 to 5 millimeters. Using a probe, we identify the dura and confirm the traversing root. After applying medial traction to the root, we identify the disc material located inferiorly and carefully remove it using pituitary forceps. To prevent root injury, we approach with the pituitary forceps from the most lateral side possible during disc removal. Complete disc removal is confirmed using the probe to verify thorough decompression. Another 34-year-old male case was superior migration. BED allowed precise fragment extraction without extensive laminectomy. This patient was similarly approached from the right side, and we used a probe to identify the disc material on the ventral side of the dura. Subsequently, using pituitary forceps, we grasped the disc material and pulled it inferiorly to remove the migrated disc. This represents a successful case of removing highly migrated disc material without requiring extensive laminectomy. We analyze VAS score, ODI score, EQ5D value, motor/sensory status, and bladder bowel recovery at 3, 6, 12 months. The clinical outcomes analyzed by repeated measures ANOVA test. Operation time, drain output, hospital stay, and complications, which includes duratomy, facet injury, hematoma, recurrence, were also analyzed. We analyzed 32 patients with mean age 44 years, L5-S1 is most common level. 94 had bladder issues, 100% saddle anesthesia, median surgery time from symptom onset is 45 hours. At 1 year, bladder recovery 87%, bowel recovery 85%, motor function recovery in 50%, and partially recovered in 22%. The recovery scores indicated that only 1 patient required ongoing assistance, no recovery, 4 had poor recovery, 3 had fair recovery, and 75.0% achieved full recovery. Among late surgeries, 70% still fully or partially recovered, but 1 patient showed no improvement. VAS score for back and lower extremities, ODI score, EQ5D value were serially improved over time. Mean OR time is 42 men, LOS is 3.3 days, complications, duratomy 6%, facet injury 6%, asymptomatic hematoma is 22%. 6 cases were showed recurrent herniated disc, 3 cases were undergone revision surgery. Previous studies showed microscopic discectomy achieves similar outcomes as conventional open surgery while sparing muscle damage. Meanwhile, minimally invasive TL life shows superior long-term outcomes compared microscopic discectomy. Uniportal endoscopic discectomy delivers 80% recovery, a 4-day stay, and 60-minute operation time, yet it is relatively contraindicated in cases with migrated fragments, heavy bleeding risk, or marked stenosis. Biportal endoscopic discectomy in cauda equina syndrome showed comparable outcomes, recovery rate, and complications. However, endoscopic surgery have risks incomplete decompression or neural injury from limited angulation and obscuring vision. In these case series study, no neurological worsening, no conversion to open surgery for incomplete decompression, which suggesting BED mitigates endoscopic risk. This is a single-arm case series with a modest sample, as cauda equina syndrome is rare, so direct comparisons are impossible. Yet by aggregating patients from 3 institutions, we assembled one of the largest biportal endoscopy-treated cauda equina syndrome cohorts to date, offering valuable multi-center insight. Biportal endoscopic discectomy offers efficient tissue-sparing decompression for cauda equina syndrome with high functional recovery and low complication rates. So biportal endoscopy is a good surgical technique in cauda equina syndrome by lumbar disc herniation. This research has been published in the Journal of Orthopaedic Surgery and Research in 2025, Volume 20, Article number 172. Thank you for listening.